Tell me about complications.
This is a very important topic because, of course, there is no operation which doesn't have the potential for complication, and there is no surgeon who doesn't see complications apart from those who don't do operations. So in this kind of surgery, they should be unusual, first of all, and they should, for the most part, be minor and manageable. There are potentially serious complications, blood clots in the leg, deep vein thrombosis, and blood clots in the lung as a result, pulmonary embolism, which have the potential to end life. Those things we manage as carefully as we can with mechanical means, graded compression stockings like flight socks and pneumatic boots which massage the legs to keep the blood circulating around, mobilising patients as quickly as possible. And of course those risks will vary from one procedure to another. In facial surgery, exceptionally rare, 1 in 10,000 plus. But in others, particularly in an overweight patient, much higher. So in those patients, we would consider using low molecular weight heparin, which is a blood thinner, after the operation to reduce the risk. So those kind of complications in this kind of surgery are exceptionally rare, but nevertheless things that we're very well aware of and manage carefully. The commonest complication in aesthetic surgery, for the most part, is hematoma. Hematoma means bleeding under the skin. In the face, for instance, when I started in my practice, the incidence was 3.7%. Published worldwide figures, 2.5 to 5.7%. Now, in my practice, it's well under 1%, for reasons that I can identify. And I'd say in the last 3-4 years, it's fallen from being about 1% to well under 1%. I say this touching wood, well under 1%. For identifiable reasons, it's not an accident. Infection, thankfully, in this kind of surgery should be very rare, and for most procedures it should be something between 1 and 0.1%, depending on which bit of the anatomy you're operating on. And again, those things depend on how it's done, where it's done, all those things being looked after. Nerve injuries, people are very rightly concerned about, particularly in facial surgery. And although they're very rare, and in experienced hands should virtually never happen, avoiding them is largely a matter of anatomical knowledge. I mean, to be honest, safe surgery generally, whether you're a neurosurgeon or a heart surgeon or a plastic surgeon, safe surgery is largely about anatomical knowledge. And then there are many specific complications. If you talk about breast augmentation, the commonest complication is capsular contracture, for instance, which has obviously nothing to do with facial surgery. In a lot of cosmetic surgery, there'll be a degree of numbness in the area operated on in the short term, but for the vast majority, that will recover. So most complications in this area need to be discussed in detail with the patient as relevant to the particular operation that they're talking about. And they also need to be put into some kind of meaningful context, so that if a complication is potentially disastrous, then, so let's say nerve injury in facial cosmetic surgery, in a facelift surgery, although it's exceptionally rare, if it were to happen, it's a very serious issue, and therefore one would discuss it with every patient, even though it's rare. If you look at eyelid surgery, for instance, blepharoplasty, if you ask the question, is it possible for sight to be damaged in blepharoplasty? The answer is yes. How? Through something called retrobulbar hematoma. Retrobulbar hematoma means bleeding at the back of the eye socket. At the back of the eye socket lives the optic nerve, which is what you see with. Bleeding around the optic nerve can put pressure on it and can damage it permanently, which in turn can damage sight. It's exceptionally rare. Again, touching wood, I've never seen it, and I only know one surgeon personally who has. So it's exceptionally rare, but it would be such a disaster were it to happen that I discuss it with every patient. And of course, if a patient already has limited vision in one eye, then you may say, if I were you, I don't think I'd do that. Because although this thing is exceptionally rare, that would be a total disaster. So discussion of complications is a vital part of counselling every patient, and it's something that one does need to be very open, very honest and very upfront with.